Ever have those times when your body just feels off? Maybe periods are all over the place, or your energy levels have just vanished. Sometimes it could be down to a hormonal thing you haven't even thought about. Today on the Deep Dive, we're getting into exactly that. Hyperprolactinemia.
That's right. We're going deep into elevated prolactin. It's that hormone from the pituitary gland. Think of this as your high-yield guide. Our mission really is to give you a clear, memorable overview for revision, hitting all the key points.
Absolutely. We'll cover the definition, the causes, the risks, how it actually affects the body, what else it might look like, the differentials, who gets it, what signs to watch for, diagnosis, management.
The prognosis, complications, the whole picture.
Exactly. And we're using those detailed MSRA revision notes as our foundation so you know it's focused. Okay, let's dive in. What exactly is hyperprolactinemia?
Okay, so simply put, is when your blood prolactin levels are higher than normal.
Right.
Generally, we're talking over 500 MIUL in women and above 450 MIUL in men. And prolactin itself, its main job, produced by the anterior pituitary, is lactation, making milk.
The milk hormone.
Basically, yeah. For context, normal levels are usually maybe 325 to 700 MUL for men, and 500 to 700 MUL for women, give or take.
So a bit high isn't always a problem, like pregnancy.
Precisely. You've got to separate physiological reasons like pregnancy and breastfeeding, totally normal, from pathological causes.
The problem causes.
Exactly. Things like tumors, certain drugs, other medical conditions, and it affects men and women differently. In women, hyperprolactin tends to inhibit gonadotrophin secretion, FSH, and LH.
Reproductive hormones.
Right, which leads to menstrual issues, amenorrhea, no periods, or oligomenorrhea, infrequent ones, and sometimes galactorrhoea, making milk when you're not supposed to be.
Okay, and for men, what's the impact there?
In men, it seems to have a more direct effect on the hypothalamus. It causes this reversible secondary hypogonadism. Basically, the testes aren't getting the right signals. So, common symptoms are reduced libido, erectile dysfunction. It really messes with reproductive and endocrine functions in both sexes.
Yeah, it definitely sounds like it has wide-ranging effects.
Yeah.
So what actually causes these high levels? What's the etiology?
Well, there's a whole range. Top of the list probably are prolactinomas.
The pituitary tumors.
Yes, benign pituitary tumors. So not cancers that just churn out prolactin. We talk about macroadenomas, less than 10 millimeter.
Tiny?
Yeah, like a pea. Macroadenomas, bigger than 10 millimeter. And then giant ones, over 40 millimeters, but they're rare. Malignant ones are extremely rare. And sometimes these tumors are part of a bigger picture, like MEN1 syndrome.
Okay, tumors are key. What else?
Medications are a big one. A real big one.
Like which ones?
Antipsychotics, some antidepressants, anti-nausea drugs, antiemetics. They can interfere with dopamine, which normally keeps prolactin in check.
Ah, the dopamine connection.
Exactly. Then you've got hypothalamic disorders, systemic diseases like chronic kidney disease or liver cirrhosis, other endocrine stuff like hypothyroidism, PCOS.
Polycystic ovary syndrome.
Right. And sometimes we just don't find a clear cause. That's idiopathic hyperprolactinemia.
Wow, quite a list. Sounds like finding the root cause can be complex.
It really can be. The diagnostic process is about ruling things out systematically. First, physiological causes pregnancy, stress. Then you look intracranial, especially for prolactinomas. Then endocrine, metabolic, drug causes. Even things like head trauma or surgery.
So thinking about who's more likely to get this, what are the risk factors?
Well, being female is one we just see it more often in women.
Okay.
Using those specific medications we mentioned, antipsychotics, antidepressants, that definitely increases risk, and conditions affecting the hypothalamus, maybe head trauma, radiation therapy nearby.
And the prolactinomas themselves. Any specific group?
Not really a strong age or a gender link for prolactinomas themselves, but one crucial point is pregnancy. If someone has a macroadenoma, there's a risk the tumor could enlarge during pregnancy. That needs careful management.
Right, important consideration. Okay, let's get into the mechanism. How does high prolactin actually disrupt things? The pathophysiology.
Okay, so it fundamentally messes with the hypothalamic pituitary gonadal axis, that HPG axis.
The communication line.
Yeah, think of it like a feedback loop that's broken. High prolactin suppresses GnRH release from the hypothalamus.
Gonadotropin-releasing hormone.
Correct. Less GnRH means the pituitary makes less FSH and LH.
Follicle-stimulating and luteinizing hormones.
Got it. And less FSH and LH means lower estrogen and testosterone. And that hormonal fallout causes the clinical features we see.
It all connects back, and I guess the exact mechanism varies a bit depending on the cause.
It does. With a prolactinoma, it's direct overproduction from the tumor cells. Plus, if it's big, it can squash surrounding pituitary tissue.
Primary effect.
Right. With meds, it's usually about disrupting that dopamine inhibition pathway. Dopamine normally acts like a brake on prolactin, and these drugs interfere with the brake.
Okay, that makes sense. Now, when you suspect this, what else is on the list? What are the differential diagnoses?
Good question. Crucial, actually. You have to think about other causes of hypogonadism. The low sex hormones.
Like
Hypothyroidism is a big one. PCOS, definitely. Other types of hypothalamic dysfunction. And remember, meds can cause transient spikes in prolactin.
you need to differentiate.
Exactly. Is it drug-induced or something more pathological? That's where investigations, especially pituitary MRI, become really important to look for tumors or other structural issues. Accurate diagnosis is key for the right treatment plan.
Absolutely. Let's zoom out a bit. How common is this condition overall? What's the epidemiology look like?
Well, exact prevalence figures are a bit hazy, but we know it's pretty common, particularly in women. Prolactinomas are the main driver of pathological cases. Estimates are maybe around 1 in 1,000 in the general population, but higher in specific groups, like people presenting with infertility or menstrual problems.
And are numbers changing?
Seems like the incidence is increasing, probably due to more testing, increased awareness, and maybe more use of those causative medications we talked about.
And the gender difference. You mentioned women more often.
Yeah, significantly. Overall incidence is about 3.5 times higher in women than men, and the peak incidence for women is in that 25-44 age range.
Prime reproductive years. Makes sense if it affects periods.
Exactly. It often gets picked up because of menstrual irregularities or fertility investigations. Prolactinomas themselves are the most common type of hormone-secreting pituitary tumor, maybe 40% of all pituitary tumors.
Wow, that's quite high.
It is. Prevalence varies a bit in studies, maybe 6 to 50 per 100,000 people. Giant prolactinomas, though, are rare, maybe 2-3% of the total, and actually slightly more common in men. And it's very rare in kids, about 2% of childhood intracranial tumors.
Okay, useful context. So let's get practical. What might someone actually notice? What are the clinical features?
It really depends on gender. For women, the classic signs are menstrual changes, amenorrhea or oligomenorrhea.
No periods or infrequent periods.
Right. Galactorrhoea, that milk production, is another hallmark. Infertility is common because ovulation is disrupted. And the low estrogen can cause things like vaginal dryness, low libido, maybe some weight gain too.
And for men, how does it typically present?
Often a bit more subtle, maybe. Decreased libido is very common. Erectile dysfunction too. Some men develop gynecomastia breast tissue. And the low testosterone can lead to fatigue, muscle loss.
Are there symptoms that affect everyone?
Yes, definitely. Firstly, many people, men and women, might be completely asymptomatic. It gets picked up by chance on blood tests.
Incidental finding.
Exactly. But if there are symptoms, especially with the larger macroprolactinomas, you can get issues from the tumor size itself. Headaches are common pressure, visual disturbances, classically loss of peripheral vision because it presses on the optic chiasm, sometimes cranial nerve problems causing facial weakness. And if it compresses the rest of the pituitary, you get hypopituitarism, symptoms, fatigue, other hormone issues, very rarely serious things like CSF leaks or meningitis.
And in children, you mentioned it's rare, but how would it show up?
Usually as growth failure or delayed puberty.
Right. So early diagnosis seems pretty important across the board.
Absolutely crucial.
Okay, so if someone presents with these kinds of symptoms, what investigations get ordered?
Initial workup usually includes thyroid function tests, TFTs, to rule out hyperthyroidism as a cause.
Makes sense.
And obviously exclude pregnancy in women of childbearing age. Then the key test is measuring basal serum prolactin.
Just a blood test.
Yep. Can be done anytime, though maybe best to avoid being super stressed right before. If it's only mildly up, say 400 to 1,000 MUL, we'd usually repeat it before referring on.
And those dynamic tests?
Generally not needed these days. Ideally, you measure prolactin on maybe 3 separate occasions to confirm it's consistently high. A level over 5,000 MUL. That strongly points towards a prolactinoma.
Okay, and if those tests come back high, what's next?
Then you might need further tests. Visual field testing if there are any visual symptoms at all.
To check peripheral vision.
Exactly. And pituitary imaging is key. MRI is the gold standard for looking at the pituitary gland, finding tumors, seeing the structure. We'd also check other pituitary hormone levels too.
Are there any tricky bits in diagnosis? Any pitfalls?
Yes, a couple of really important ones to know for exams. First is macroprolactinemia.
Macroprolactinemia. Okay.
This is where you have high prolactin levels on the test, but the patient doesn't really have symptoms. It's because the prolactin molecule is bigger, clumped together, and less biologically active.
So the test picks it up, but it's not doing much.
Pretty much. We can use something called PEG precipitation to measure the free active prolactin if we suspect this.
Okay. What's the other pitfall?
The high-dose hook effect. This can happen with very large prolactinomas producing huge amounts of prolactin.
Right.
The sheer amount can actually overwhelm the assay, the test system, and paradoxically give a falsely low or moderately elevated result.
That sounds dangerous.
It can be misleading. So, if you see a large pituitary tumor on MRI, but the prolactin level isn't sky high, you must ask the lab to do serial dilutions of the sample to rule out the hook effect.
Good tip. Okay, so we have the diagnosis. How do we manage hyperprolactinemia? What's the general approach?
Fundamentally, you want to address the underlying cause if you can and relieve the patient's symptoms.
Right.
The goals are fix the menstrual issues, the galactorrhoea, the ED, the low libido, prevent long-term problems like osteoporosis from low hormones or pressure effects from tumors, and, where relevant, restore fertility and normal sexual function.
And specifically for prolactinomas, what's the management?
Okay, if it's a small microprolactinoma and it's asymptomatic with maybe only slightly raised prolactin, we might just monitor. Most of them, 90–95%, don't actually grow much.
Watchful waiting.
Kind of. But treatment is needed if the tumor size is causing problems, headaches, vision changes, or if the high prolactin itself is causing bothersome symptoms like infertility or sexual dysfunction.
And what is the treatment?
First line is almost always medical, dopamine agonists.
Like cabergoline.
Cabergoline and bromocriptine are the main ones. They mimic dopamine, hitting the brakes on prolactin secretion. And crucially, they also shrink most prolactinomas.
Oh, that's good.
It's very effective, often needs long-term use, but sometimes under specialist care, a trial-off medication can be considered later. Cabergoline is often preferred, it tends to work better, and you take it less often, maybe once or twice a week.
Are there downsides to these drugs? Cautions?
Yes, a few important ones. Very rarely, particularly with higher doses sometimes used for Parkinson's, there's a risk of cardiac valve fibrosis or pulmonary fibrosis. Yes, needs monitoring. Usually echocardiograms periodically if higher doses are used long-term. Common side effects can include sleepiness, nausea, dizziness, and sometimes impulse control disorders like gambling, hypersexuality need to warn patients.
Right.
And watch out for low blood pressure, especially when starting. Surgery, usually transsphenoidal, through the nose, or radiotherapy are options if the drugs don't work, aren't tolerated, or for specific situations like acute vision loss.
What about during pregnancy? You mentioned the tumor growth risk.
Yeah, that needs careful planning and specialist input. Small risk of enlargement, mainly with macroadenomas. If new symptoms like headaches or vision changes pop up during pregnancy, it's an urgent referral.
Can they take the meds during pregnancy?
Yes, both bromocriptine and cabergoline are generally considered safe options if treatment is needed during pregnancy.
Okay, and for drug-induced hyperprolactinemia?
The ideal first step is to stop the offending drug, if clinically possible.
Switch medication, maybe.
Exactly. If stopping isn't an option, or if symptoms persist, you might consider hormone replacement for the deficiency, or sometimes even cautiously try a dopamine agonist. And for macroprolactinemia, that less active form usually doesn't need treatment.
Okay, so summarizing management, prescribing, and non-prescribing.
Key points. Refer to endocrinology. Dopamine agonists are first-line drugs, cabergoline often preferred, maybe bromocriptine if planning pregnancy soon. Regular MRI monitoring is standard to check tumor size and response. Hormone replacement estrogen, testosterone might be needed for symptoms if fertility isn't the immediate goal. Surgery and radiotherapy are reserved for when medical therapy fails or isn't suitable. It's really a multidisciplinary team approach often.
Got it. What about the long-term outlook? The prognosis?
Generally, it's good with treatment. Depends on the cause, the size of any tumor, and response.
And for prolactinomas?
Microprolactinomas can sometimes even resolve on their own, maybe a third of women, especially after menopause or pregnancy. Specialists might trial stopping dopamine agonists after, say, 3 years of good control, normal prolactin, tumor shrinkage to see if it's still needed.
Any idea about recurrence rates after stopping?
Yes, there's data on that. For macroprolactinomas, if there's no visible tumor left after treatment, the 5-year recurrence is maybe around 33%. But if there is still some visible remnant, it's much higher, maybe closer to 78%.
Big difference.
Yeah. For micros, it's lower, maybe 26% recurrence if no remnant, 42% if there is. It just underscores why long-term follow-up is so important, catching recurrence early.
Makes sense. Finally, what are the potential complications we need to be aware of?
Several things. Complications from the hypogonadism, the low hormones. Osteoporosis is a big one.
Bone thinning.
Right. Affects maybe 25% of women and can persist even after prolactin normalizes. Men with prolactinomas have about a 5 times higher risk even after treatment. Reduced fertility, erectile dysfunction, those are direct consequences too.
And from the tumor itself.
Mainly with macroadenomas. Visual loss, headaches we mentioned. Pituitary apoplexy is a rare emergency. Sudden headache, vision changes, altered consciousness due to bleeding or infarction in the tumor, more likely in bigger tumors.
Scary.
It is. Very rarely, rapid tumor shrinkage with dopamine agonists can cause a CSF leak fluid leaking from the nose, and malignant prolactinomas are extremely rare but obviously serious. Then there's the ongoing impact on sexual function and fertility for many.
Okay, this has been incredibly comprehensive, so just to quickly recap. Hyperprolactinemia means high prolactin. Key causes are prolactinomas in meds. Think menstrual issues, galactorrhoea in women, libido and EE issues in men. Diagnosis involves blood tests, ruling things out, often MRI. Management focuses on the cause, usually dopamine agonists, first line for prolactinoma.
That's a great summary. Understanding those core points is absolutely key for your MSRA revision.
It really drives home how interconnected hormones are and how disrupting one, like prolactin, can cause ripples throughout the body. Definitely something to think about more broadly with endocrine disorders.
Absolutely.
Now, if you're revising for the MSRA and want more top-tier resources, definitely check out pastthemsra.com.
And don't forget freemsra.com, another excellent accessible resource for your prep.
Thanks so much for joining us for this deep dive today.